Good afternoon, colleagues and teachers. Today I'll take the class further in MRI in ophthalmology. Uh, Now we'll see the sub. To take in detail how we will read an MRI film to find any pathologies. First, we'll place the MRI film in the view box and see the location or the compartment of the lesion where it is intracanalicular, intraconal, extraconal, intraorbital, involving lacrimal gland. What is the extent of the lesion if it is involving more than one structures or extending into the intracranial part? What is the morphological characteristic of the structure if it is well circumscribed or diffuse or homogeneous or heterogeneous involvement? What is the characteristic of the lesion in T1 weighted image and corresponding characteristic of the lesion in T2 weighted image? If any spatial sequence is done, flare or steer, how the lesion is reacting on the spatial sequence, and if contrast is done, if it what is the nature of lesion in the contrast, and then we will correlate it with the clinical findings and list the differential diagnosis. So first, we'll discuss the lesions in the orbit. Can be divided into inflammatory, infectious, neoplastic, or vascular lesions. Inflammatory can be a thyroid eye disease, idiopathic orbital inflammations, infections like orbital cellulitis, orbital abscess, orbital cysticercosis. Neoplastic lesions like benign lesions like dermoid, malignant lymphomas, rhabdomyosarcomas, adenocystic carcinomas, vascular lesion involving AV malformation, orbital varix, kerotico-cavernous fissulas, cavernous hemangiomas, and lymphangiomas. Uh, Inflammation, first we'll discuss thyroid eye disease will in on MRI will find the active disease and differentiated with chronic disease. The muscles extraocular muscles will show hyperintensity in T2 weighted image in active disease, and compared to T1 weighted image will show iso intense on the T1 weighted image. The enlargement of muscle we can also see in the T2 weighted image. Here we can see the involvement of inferior rectus muscle, medial rectus muscle, and superior rectus muscle in the right eye, suggesting the active disease in right eye. Here, the stir image on T2 weighted image will show us active disease, suggesting hyperintensity. Here, we can see the stir sequence showing hyperintensity in inferior, medial, and superior rectus of both the eyes, suggestive of active disease. MRI is also helpful in thyroid eye disease to see the involvement of optic nerve. Okay. Idiopathic orbital inflammation, it will be localized or it is localized or diffuse inflammation of orbital soft tissues. It may involve the soft tissues of orbit like muscles, lacrimal gland, orbital apex. Here the image shows a T1 weighted image, intense, showing the involvement of lacrimal gland, well circumscribed lesion of the lacrimal gland on T2 weighted image, active inflammation showing hyperintensity, suggestive of inflammation in the lacrimal gland. And here, involvement of muscle with diffuse and isointense lesion involving muscle, belly, and tendon suggest. And on T2 weighted image, the intensity of the lesion we can which suggests a inflammatory disorder. In orbital cellulitis, there will be diffuse infiltration of the soft tissues on hyperintense on T2 weighted image, and on contrast, it will show hyperintensity. There will be retroorbital fat stranding. Here we can see the fat stranding in T1 weighted image with multiple enhancement of the fat containing tissue, diffuse thickening of the muscles, and ill-defined margins, suggestive of inflammation in left eye. The enhancement. The post-contrast image is showing the enhancement of the inflammatory area of the orbit, associated inflammation of maxillary and ethmoidal sinuses. It is very sensitive for diagnosis of cerebral venous thrombosis associated with orbital cellulitis, which will be hyperintense on MRI, which is normally seen as a fluid void areas. In intraorbital abscesses, T1 weighted image, intraorbital abscess will be iso-intense on T1 weighted image, and again the fluid containing tissue will be hyperintense on T2 weighted image. Post contrast image will show a enhancing ring lesion in a well circumscribed rim lesion with intraorbital abscess. Here in this image, we can see the involvement of sphenoidal sinus, where an extension of the orbital abscess into the orbit, which is hyperintense in T2 weighted image, and post contrast, it is showing ring enhancement.
What is the other sequence you would see the abscess well? It was
Ma'am,
discussed in the previous class in her. There's one sequence where the abscess will stand out. You need not even give contrast. You have that particular sequence. Contrast is given basically to look for cavernous sinus thrombosis, to outline the abscess. What is the sequence? Diffusion weighted.
Sir, and T1 normal structure will be well appreciated. In T2 weighted images, the pathologies are much more easily appreciable. Sir, it depends on the pathology.
Run is used for anatomy, and T2 will characterize the lesion better. So it will tell you whether a particular lesion is solid, cystic, what is the consistency, what is the composition of that particular tissue.
In orbital cysticercosis, the cystic lesion on T1 weighted image will appear darker as the other fluids, and in T2 weighted image, it will be hyperintense. Here, the cystic lesion is seen in the superior rectus muscle with eccentric nodules suggestive of colics and uh, hypointense cystic fluid, and the similar lesion is seen on a hyperintense and T2 weighted imaging, uh, suggestive of fluid in the lesion.
What is the other modality in which you can identify the scolex?
Ma'am, we can identify on CT scan and USG, but on superficial, like surface,
So basically
superficial lesions.
intraocular and anteriorly located cysties you can pick up on ultrasound because that's easily available. But if you have deeper lesions, then you cannot.
In cavernous sinus hemangiomas, there will be iso-intense on T1 weighted image and hyper-intense on T2 weighted image. The characteristic post-contrast feeling of the lesion will show central feeling and progressive feeling of the whole lesion during the late venous phase. In lymphangiomas, MRI will show a multiloculated heterogeneous lesions, multiloculated heterogeneous lesion with a fluid level. The part of the lymphangioma containing lymph will be darker in T1 weighted image and hyperintense in T2 weighted uh, will be darker in T1 weighted image and hyperintense in T2 weighted image, while more proteinaceous and subacute hemorrhages in lymphoma will be darker in T1 weighted image and hypointense in T2 weighted image. Here, the lesion is showing multiple cystic areas with a fluid level in the anterior part of the lesion.
What does the fluid level indicate?
Ma'am, the different content of the lymphangiomas, so lymph more proteinaceous content and cystic lymphatic content.
So the
So
proteinaceous content will be
the
like will be down.
less
It's more indicative of a intracystic hemorrhage
hemorrhage.
or a bleed.
The lymphangiomas does not show enhancement on contrast imaging. So AV malformation on T1 weighted image will be iso intense and T2 weighted image, fat suppressed image, they will be slightly hyperintense. The lesion will show multiple fluid void areas due to presence of large capillaries in the lesions. In keratoconus fistulas, the enlargement of large and hence enlargement of cavernous sinus with superior ophthalmic vein will be seen as a fluid void areas in T2 as well as T1 weighted image. On MRA, we'll see hyperintense enlarged superior ophthalmic vein with enlarged cavernous sinus.
What does that hyperintense superior ophthalmic vein indicate on MR angiogram?
Its connection to the carotid artery because it is arterial. It is MRA. So
So, what
direct
does it indicate when there is a bright signal in the
in
everything is bright there, no?
communication.
What all the vessels are bright. It indicates that there is a flow in that.
Right. Yes.
Okay. Because you can get a dilated superior ophthalmic vein in SOV thrombosis, but when you do an angiogram, you will not see flow in that. Okay, so that's how you differentiate also between patent vessel versus a thrombosed vessel.
In rhabdomyosarcoma, as the muscles are seen hyper, I it will show homogeneous solid lesion on T1 weighted image as muscles are dark in the T1 weighted image. Will post contrast as muscle enhances. The whole lesion will show enhancement. So gadolinium enhancement is the best diagnostic modality for rhabdomyosarcomas and to evaluate the extent uh, of the rhabdomyosarcomas. In pleomorphic adenomas, they are well-defined heterogeneous lesion containing multiple cystic spaces. The cystic spaces are hypo-intense in T1 weighted images, which shows enhancement in T2 weighted images, and the lesion are well circumscribed, and mark enhancement is seen post-contrast. Compared to adenocystic carcinomas, there will be heterogeneous, irregular, well circumscribed lesion, which can show, which can invade the bones, and intracranial involvement can occur in adenocystic carcinomas. They will also be hypointense in T1 weighted image and hyperintense in T2 weighted image. They also take a contrast enhancement. Uh, Intracranial extension is important to rule out these lesions. Intraocular lesions like retinoblastoma, MRI is the main investigation for diagnosis and to evaluate the extent of the lesion. In T1 weighted image, the retinoblastoma will be iso-intense or slightly hyper-intense compared to T2 weighted image. It will be hypo-intense, but due to a vitreous enhancement, we can delineate the lesion better. And to evaluate the involvement of optic nerve, post-contrast enhancement will be better picked up to see the optic nerve involvement. In choroidal melanoma, due to paramagnetic properties of melanomas, they have shorter T1 and T2 relaxation time, so will appear brighter, hyperintense in T1 weighted images and hypointense in T2 weighted images. So MRI is the choice of investigation in cases of uveal melanomas. Optic nerve lesions. In optic neuritis, MRI is the investigation of choice to see the to make the diagnosis of retrobulbar optic neuritis will show post contrast enhancement of the optic nerve. Here, the left optic nerve enhancement is seen compared to right optic nerve post contrast, and also to evaluate the demyelinating lesions in the brain. T2 weighted image flare images suppressing the CSF signals will show finger like periventricular demyelinating lesions in optic neuritis. Uh, Papilloedema, choice of investigation is MRI with MRV. MRI to rule out any space occupying lesion in the brain. T2 coronal T2 weighted imaging will show at the level of optic nerve will show enlarged CSF space around the optic nerves, and in cases of idiopathic intracranial hypertension, empty cellular sign will be seen. To rule out cerebral venous thrombosis, MRV is done. Here, the MRV image, we can see the fluid, the absent of the venous integrity, suggestive of um, venous sinus sagittal venous sinus thrombosis
Absent what? Absent flow.
flow.
Okay. And what sinus are you pointing to?
I'm sagittal. I'm sagittal sinus. Yeah.
What? Which sinus?
Sagittal one.
Superior sagittal
Superior
sinus.
sagittal sinus.
So your papilledema protocol should include a venogram and a contrast also. Okay, so nowadays we do a contrast enhanced venogram because there may be some artifact and some false positive kind of on a routine MRV. Okay, you might see an accentuated stenosis or you might see a filling defect. So that all those drawbacks are overcome by giving a contrast, doing a contrast venogram.
In optic nerve glioma, there will be iso-intense and T1 weighted imaging and well circumscribed diffuse enlargement of optic nerve with the ISO to hyperintense and T2 weighted images. Uh, there will be homogeneous enlargement of optic nerve in optic nerve gliomas. In optic sheet meningiomas, we can see the tram track enhancement of optic nerve sheet in axial section showing tram track sign. In coronal section, we can uh, see the enhancement of optic nerve sheet with a central normal optic nerve in optic nerve sheet meningioma compared to glioma, which will show homogeneous hyperintense lesion. Intracranial lesions like optic chiasmal lesion, pituitary adenoma will show in T1 weighted post contrast image will show a homogeneous hyperintense enlargement of pituitary gland compressing the optic chiasma from below,
All
wherein
pituitary tumors are not homogeneous and hyperintense. It depends on the content of the tumor. Okay.
yes, ma'am.
If they're solid, they will enhance like this. If they're cystic, they will show rim enhancement. If they're mixed solid and cystic, then the solid component will enhance, the cystic will not enhance. So this is just
Uh,
one pattern of enhancement in a pituitary adenoma. So
uh,
what you're showing down is a mixed solid and cystic tumor. Okay,
yes.
so what is enhancing in the inferior part of the tumor is a solid component, and the rest of it is a cystic component. And then you see the rim enhancement.
As in
For
cranial.
craniopharyngiomas, when you suspect, you should always have a complementary CT to pick up the calcification.
Necrosis is dark on T1.
Acute ischemic lesions, MRI is the choice of investigation to evaluate retrochiasmal lesions. In acute presentation of a retrochiasmal lesion, first we'll go for CT scan to rule out any acute hemorrhages, followed by MRI with or without contrast. Uh, in suspected ischemic lesion, DWI image will show hyperintense lesion. Here, a DWI image is showing a ischemia due to middle cerebral artery, and corresponding ADC image will show a hypointense lesion suggestive of acute infarct. In cases of subacute or chronic infarct, the DWI image will be brighter, but the ADC image corresponding will not show hypointensity in subacute or chronic lesions. So what we will choose for investigation in various clinical scenarios, like if the proptosis is there and we suspect thyroid ophthalmopathy or orbital pseudotumor or cellulitis or any inflammatory disease, we can do CT scan or MRI. CT is sufficient, but MRI is required to rule out orbital apex involvement or involvement of cavernous sinus. In a Suspected vascular orbital lesions, CT scan or MRI scan can be done. CT scan if will pick up calcification, bony erosions, and subperiosteal lesions, while MRI will be done to see the optic nerve involvement and intracranial extension of the lesion. Suspected AV malformation, MRI, is investigation of choice, but Doppler imaging will help to see the flow of the lesion, if it is high flow or uh, low flow lesion. Keratoconus fistulas, MRI with MRA or CTA can be done. Doppler imaging will show the flow in the lesion. Orbital cysticercosis, ultrasound, CT or MRI can be done. You we discussed ultrasound for superficial lesion. CT scan will pick up the calcification in the lesion, and MRI to see the age of the uh, activity of the cysticercosis, and brain MRI in orbital cysticercosis patient to rule out any neurocysticercosis. In optic atrophy, MRI is the choice of investigation to rule out any compressive.
One second, I think you can just summarize this slide. In most neuroophthalmic situations, conditions, you would do an MRI. Okay, full stop. So if you have a cranial nerve palsy, especially a pupil involving third nerve or a sixth nerve, you should always do an angiogram along with that. Okay, that is as a protocol we do it. But suppose if you are in a place where you're not familiar with the radiologist, then you can just mention that you need to do an MRI and MRA and MRI.
In cases of traumatic optic neuropathy or penetrating trauma, CT scan is the choice of investigation to look for any fractures, metallic foreign bodies, or any bony fragment impinging the nerve. In or by dermoids and neoplastic lesion, CT with MRI to see any calcification or bony remodeling, and MRI to evaluate soft tissue involvement and optic nerve involvement, intracranial involvement, and any unexplained diminution of vision. MRI should be done to look for any lesions in the optic visual pathway.
So for RB, we no longer do CT scan. Okay. For retinoblastoma, now MRI with contrast is the modality of choice. Okay. One is because it's a pediatric patient, you do not want to subject them to radiation. And you can actually see the tumor on MRI, which on CT is only seen as calcification. You can see the tumor, you can look at the extraocular extension, optic nerve invasion, and leptomeningeal disease. Okay, which CT is not sensitive in picking up intracranial spread. So MR with contrast is the modality for RB. MR with contrast for all intraocular tumors. Okay, so that is how you should remember.
Of second tumors if you
Yes.
do CT on a retinoblastoma, right?
Yes. Bone
Mesenchymal
metastasis.
tumors. So thank you, Asta, and thank you, Rahima. That was a very useful class on MRI. Many times we are confronted by patients who come with a bunch of MRI and we go straight to the typed report. But now I guess people listening to this will be tempted to take a look. If you have a viewing box to, otherwise it's difficult to see under the light like that. But if you have a viewing box to take a look at the scans and make your own interpretation. And it's very important to inform if you're suspecting nerve palsy to where is it nuclear or infranuclear or supranuclear. It all depends where you are suspecting the pathology is, and to inform the radiologist about that so that they can do their neuroimaging um, corresponding to that. Okay, I think we'll call it a day unless anybody else here has got questions.
Okay. Thank you so much.